We're here today on a February day in 2019 with Dr. Ron Dunlap, who is past president of the Massachusetts Medical Society during 2013 and 14. And welcome.
Thank you.
So tell me about what it was like when you were president. What were the things that captured most of your attention?
I think the impact of the Affordable Care Act was probably the major thing, in that not only were we forced to look at electronic medical records, but we're also looking at the transformation in really payment, which was really driving the formation of accountable care organizations. And the problem was that we're always about 2 or 3 years behind where we should have been. Mm-hmm. So we did a major initiative that year, which was unusual, in that the leadership of the society accompanied me to meetings all over the state. These were not district meetings. These were just problem-oriented meetings to explain to physicians what was happening. We had as many as 150 people attend those sessions, so that was unusual. The electronic medical record thing was a major problem. That I had spent about 4 years with an international group developing an electronic medical record. Mm-hmm. These were academics from the 3 Boston hospitals and people from Pakistan and India, actually. These are programmers that had worked on NextGen and some of the major systems. So we were quite advanced, but we ran into the political wall in the state that the $55 million of Obama money was designated to a group of people who had done a project that it basically failed. Yeah. So we offered our software for free to the neighborhood health centers to put them on one software. The Boston centers were on 9 different softwares. Yes. But we were unknown at that time. That was a year before I was elected vice president of the society. So at that point, you're unknown to the legislators. And I think Alice Coombs and our EV at that time, Corinne Broderick, got us an appointment with the Secretary of Health and Human Services, who then placed us on a board, but at that point all the decisions had been made. So we ran into the problem of one of the representatives wanting all of doctors to certify for meaningful use, when in fact only about 55% were eligible, which would have made, to get your license, which would have made 45% of the practitioners in Massachusetts unable to be licensed.
So there's a whole lot that you just got into here, because the Affordable Care Act was President Obama's attempt to develop access to health care for everyone at a time when roughly 15 to 20% of people didn't have health insurance in the United States, and it was modeled to a great extent after what had been done in 2008 in Massachusetts. And so we were already rolling with that, but there were elements to that legislation that changed things for the people working in Massachusetts as well.
Correct. And so that transition, and we're still in the midst of it, because now we're being asked to take on risk. Mm-hmm. And only a third of the organizations doing that in the past year were successful, and most of them opted not to do the next step, including Dartmouth, who wrote the book on ACOs. So in the past year, I brought a resolution to the AMA for due diligence for physicians and organizations looking at joining a risk-bearing ACO, to look at what factors you had to look at. Because what's happening is physicians are joining groups that fail, and then when the group fails, a hedge fund or someone else buys you out, and your life changes.
So there's a whole lot here. Let's focus on a couple of things that you brought up, because each one is so interesting. One has to do with the technology of electronic medical records, and the fact that at the point in time when you were president, and still to a large degree, they're not compatible with each other. No. Information doesn't flow from one office to another or one institution to another. They're designed by people who may not have the perspective of someone who's seeing patients, and so the workflow gets disturbed. And so you were immersed in that. You've got experience using them and experience developing them. So talk about that a little bit.
So when we developed it, I spoke at the State House about interoperability. They didn't know what we were talking about. And I worked as a biomedical engineer for Hewlett-Packard, now Philips. And in the early 90s, the government came forward and said, we have to develop a uniform standard for imaging, which is DICOM. and the 5 top companies were brought in and told, you must do this. Your information has to work on everyone else's system. This is why we can look at a CT scan on our home computer. So the government had a history of mandating this, but yet they failed to do this with the electronic medical records. So the state in turn approved 15 different systems, none of whom communicated with one another.
And this was for a big experiment that was sponsored in part by the Blue Cross Blue Shield Foundation and involved 3 communities in Massachusetts and trying to just wire them completely.
Right.
The idea was we're going to wire these communities, they're going to talk to each other, we're going to see if this works.
And 2 failed outright, and the third was on the North Shore, and they were having trouble extracting information from the system. So we had put together 5 companies, people who were doing the Defense Department security. We had the software people who wrote the programs for Bank of America. We had our medical software group. So we had a consortium of 5 companies. So we actually went to Newburyport to see if we could help them extract the data. And at that point, the software being used, the clinical work, you couldn't do it. Subsequently, they've done it, but I think in the interim, they've lost a lawsuit because of promises and things that they weren't able to. So the state put forward this Massachusetts eHealth Institute, and I sat at a meeting at the IT committee next to the person who headed that for 3 hours. And the next week, when I testified at the State House, he said, "Who's that black guy over there?" So, I mean, I wonder how many black guys that do software and are doctors that he runs into in a week. But that was the extent of it. So there were no physicians on that board. So it's understandable that we therefore develop software and approve things that doctors don't use.
And what had happened was legislation, the legislators are ahead of the technology and they're ahead of the implementation. So they were in the process of passing a law essentially mandating physicians using electronic health records before the technology was ready to even be used.
Exactly. So we had already designed software that was partly educational. We had programs that when you write a drug, it would look at the healthcare plan and tell you which antacid or anti-anginal drug you could prescribe for that patient to save you time. We also, when you ordered a CT scan, it was to look at the current indications for that, sort of to steer you to the right study.
Putting
So we were,
artificial
this is a very,
intelligence in.
we had gotten consultants from around the country and around the world to look at this. So this is a really comprehensive thing. But
So who is we? Who is we?
So one of my patients was a clinical pathologist at Tufts. There was someone from Dr. Young from BU's School of Business. There was a fellow named David Croston who does security for the power company and the Defense Department. So, you know, most of our energy plants are not protected, and so they're open for attack. So David developed software that protect them from being hacked by the Russians or whomever. So it was, and then we had a former head of department at Kaiser, who's in a team from Kaiser, and Shepard Chow, who is a brilliant engineer who was born in China. He and his brothers went to Caltech and Stanford. One of his brothers has written the business plan for CVS. Shepard has done analysis and efficiencies and cost accounting for everyone from medicine to oil companies. So it was a pretty powerful group, but they didn't know who we were.
And convened under what? Was this a Massachusetts Medical Society group, or was this outside?
The Massachusetts Medical Society was kind enough to give us a room to meet.
Okay.
But we were all doing this on our own time.
Terrific.
So this is a 4 or 5 year project. That,
Yeah.
So we kind of knew where we should go.
Yeah.
And then you have to now witness where we did go.
Yeah.
And this was a problem.
Okay. So there's the electronic health records piece that was really a focus during your time as an officer. And then the other piece of the Affordable Care Act had to do with encouraging the clustering of physicians into a rather industrial model called accountable care organizations, in which instead of selling piece-by-piece services, they would essentially take responsibility for populations of people.
Right. So my major concern with that was not the Accountable Care Organization, but the fact that the Accountable Care Organization was acting as a tool to consolidate physicians because of fear of not having the money to really affect all these changes and put the organization in place. And in fact, in the past year, we found out that physician-run ACOs saved an order of magnitude more, $360 over $306 or so from large hospital-driven systems.
Right, so
but we were trying to prevent that. We're saying to our colleagues, organize, do
Right.
this yourselves, have control over your future, and have a say. And even if you work with a hospital, have a say in governance.
So what you're describing is that the place that is most heavily populated with administrative support and everything is the hospital systems, and the hospital systems also were far and away the most expensive and inefficient corners of the healthcare system. And so as they pulled physicians under their umbrella with the promise of providing administrative support, they did not shed their inefficient habits.
Right. And then the worst thing about the electronic medical records, other than the fact that they're not very easy to use, was the cost.
Yep.
So last year I took a resolution to the AMA looking at the impact of the high cost of hospital EMRs. And I walked into my hospital on one morning and 90 people had been laid off. My wife came home and said 90 people at her hospital had been laid off. And both hospitals were always in the black and now in the red because they had made a $200 million commitment to Epic.
Right.
And so I went online and started reading, and all of a sudden, this is a nationwide phenomenon.
Yes.
That hospitals were spending this money, and the question of whether you would recover that. So $200 million on the South Shore given to me to treat patients for 5 years, I could clearly improve the health care of the people on the South Shore. After $200 million of Epic money, I'm not sure if I can do the same thing.
So you bring up another interesting point, which is that the history of electronic medical records, besides them being expensive and being difficult to use, is that there's a history particularly of health systems purchasing a system and then finding it unworkable, abandoning it, and moving to something else. And as a result of that, they tend to engage in sort of mimetic behavior where the safest decision to make is the decision that everybody else has made.
Right.
And,
so the herd followed, and
Right.
there's like a Pied Piper type thing.
Right.
And now, so a friend of mine headed a system at one of the major hospitals, and the biggest, well-known hospital, and they're having problems. They had a crash last week. It's not that I'm clearly not anti-electronic medical records. What I was in favor of is a useful tool. So it turns out in the past year, talking with people at IBM Watson and American Society for Oncologic Research, other groups, they have their software people all working on artificial intelligence to be able to extract from a dictated note the key information, because there's a conflict between data acquisition and a narrative, which is what we were taught to do. So if that could return, then these systems will become very useful to us again, because we can spend time with the patient. I would see the patient, and then I would dictate my note in 10 minutes, and I have
it'll pull the meds out, it'll pull the allergies out, it'll pull the problems out.
So there are all these, the problem with America is that
spelling.
there's probably 20 people working on this. In Japan, they would assign 3 companies to do this. I ran an electronics company of my own for 10 years, and so when they did the VCR in Japan, they gave money for VHS, and it's only developed Beta. Beta was better than VHS, but the government was behind it, so that's what got adopted. But in fact, because of our competitive society, we have all these 400 companies trying to develop an EMR, when a certain amount of cooperation could have been much more useful.
Right. Right. In fact, they essentially found benefits to providing incompatible software so that you could not.
That's marketing. That's the way it's done.
Right.
So,
you couldn't walk from one
even if you
program to
bought
another.
the same software, if you had a different version, it might not talk to another. And then between competitive issues between systems, privacy and concerns and safety concerns, there was a rationale for not making it interoperable. And I think now the government in the past week is now starting to enforce the first standards for interoperability.
Good.
So that was a huge point. But one of the things I was concerned with was health equity and disparities. So I served I was appointed by the Medical Society to be on the Commission to End Healthcare Disparities. And one of the things that I noticed was that in my year as president, more people saw a primary care doctor than in the history of the state. Okay. However, there were still pockets, we theorized, that were underserved where they weren't getting care. So we got that group together and proposed a study called the Massachusetts Care Map. And we got a hold of databases for Medicare, Medicaid, extensive U.S. Census data, Mass Medical Society studies, and we wanted to do the study, but it was when Obama was running for president, and we were concerned that perhaps putting universal health care in a bad light was not a good thing to do at that point. So we reversed, that was 2012, we reverse engineered the study with the data we had, and we were able to show the 15 most underserved communities. And in fact, the ratio of physicians to patients wasn't the problem. It was the fact that in high impact areas with a lot of Medicaid patients, the number in your practice would overwhelm the practice. So once you got up to 20 or 30% Medicaid patients, your practice became financially non-viable.
That's, and so you bring up another issue, which is that various insurers at this time pay significantly different amounts, and Medicaid, which is the government program for the poor, often pays below cost.
Right.
And so if someone opened their doors to all of the poor patients who needed them, they may not be able to keep their doors open.
Right. So I did a little practice calculator, and I take 2 doctors, and I take real overhead for the South Shore, and I show the profit for no Medicaid, then 10%, 20%, and I show the point at which you become non-viable.
Nice.
And so this is the problem. It's really an attribution problem. So unless you can split the load evenly, we had the benefit on the South Shore being a cardiologist. I could take Medicaid because most people weren't on Medicaid, and if I didn't get paid, this is before, it didn't matter as much because I had a payer mix that allowed me to survive.
You could absorb it.
Yeah, so you can absorb it. But if you're in Quincy or you're in Cambridge, I spent some of my internship and residency in Cambridge. We were treating poor people. Different story. Boston Medical Center, different story.
So you bring up a very interesting point regarding our current insurance system versus, to give you an example, some European systems which may have many insurers, but they often have a fee schedule. Whereas in the United States, there is no fee schedule, and so there's a lot of cost shifting going on. So which that was undermines the stability of the system.
So in 2016, I focused on the impact of high deductible health plans. Wrote a resolution, took it to the AMA, and they had been in favor of high deductibles, so they were a bit embarrassed to have it pointed out that this was actually counterproductive. So they made a lot of it reaffirmation, but it actually went to the heart of the matter. That there's over $100 million per year and now being shifted to patients annually. So the Mass Medical Society did pick up on it and published a booklet or pamphlet on the impact of high deductible health plans. So I felt my work didn't go, no good deed goes unpunished, or so they say. So, but it was an experience at the AMA. I've been successful with my last 3 or 4 things that I've got them to look at.
So you point out that during your years as an officer, and particularly as president, you've looked at access, you looked at electronic health records. You also were describing the industrialization of healthcare, and that doctors were being moved into large healthcare organizations. And you also alluded to the fact that these organizations were not particularly successful and often not successful either financially themselves or in saving the system money.
Right. So what we see now is, so the end result is if you consolidate physicians into a group that doesn't save money, the group goes under, you now have hedge funds buying it. So in the past month, 2 practices on the South Shore have been bought out by hedge funds. So the physicians don't see the 10,000-foot view.
Right.
They're sort of ready to sign on the dotted line, not understanding ACOs or what's going on at all. But I'm trying to tell them, look, you want to form a group and deal with the system, but maintain an independence. So if the system goes down, you can move your contract to another organization. So people are unaware that systems like Mayo, Cleveland are looking at buying hospital the size of our hospital in the Boston area. They're totally in the dark about the fact that there's a national plan. I talked to a man who runs nonprofits, large nonprofits, and I asked him 2 years ago what the future of medicine was, and he said 7 to 10 large systems. So that's Mayo, Kaiser, Cleveland Clinic, so on. And so even our systems here, we have partners and others trying to become national and international companies. So that involves a lot of consolidation of a lot of people, and more consolidation you go, the bigger the fish that buys your system, the lower the physician falls in the governance tree.
Well, the other piece of this is much of this consolidation has been sort of classic monopoly policy in the sense that the economic model has allowed these large organizations to extract higher fees. It hasn't cut the cost of health care.
No. So the major concern now is the cost shifting with the cost accounting allows you to now, charge large academic center prices for a medication or a biopsy or whatever. And the Globe has written a couple of articles recently about that. There was a woman who had a biopsy for $100, went back to the doctor after it had been consolidated, it was $1,000.
Yeah.
Same procedure. So this is an issue. So there's a move to get bigger and to dominate, but the focus is not necessarily saving money.
Right.
It's about consolidating the physicians first. And then the question is, are you truly able to organize this to save money? And it appears that administration is a huge part of the cost. And so it's not the physicians that are driving that cost, and that's not well known to the public. And so even on the, I'm the Medical Society representative to the advisory board for the Health Policy Commission. And I would say I'm probably the only truly practicing physician on that. The head of partners is on, the head of steward, all these people.
Right.
There are good community groups and so forth, but the focus of these very bright people with very sophisticated degrees is policy, but they've never been on the ground and in the field.
Right.
So it's like it's like the NFL, the little guy who does the NBA. The guy who does the Patriots is about 5'5", 120 pounds. He's never played a down of football in his life, but he's pontificating about how good Tom Brady is or bad he is. Well, that's basically what we have. So there needs to be a better interaction between our policy people and a better interaction with the patients, which is because I think we can move policy by perhaps educating patient groups and letting them take the ball, like the woman who fought against the EpiPen. And that was all social media, and they got that price down. And I think there's a recent interview on 60 Minutes where the head of a drug company said, well, he was raising the price to increase the accessibility, and 3 weeks later he lowered his price by 2 orders of magnitude.
So when did you join the Massachusetts Medical Society?
I joined them as probably, I think it was around 2000, 2001. It was right around the time when, just before I'd been approached by this group to try to develop this electronic medical record. So somehow I always ended up, and my company was in Waltham, and Hewlett-Packard was on Wyman Street in Waltham. So I spent a lot of my time shuttling back and forth between the medical school and Waltham for one reason or another. So it seemed
you were in the neighborhood.
Yes. So it seemed like things hadn't changed.
And how has the Medical Society evolved in the 19 years or so that you've been a member?
I think it's always been, unfortunately, very active legislatively, but as a defensive organization. We keep bad things from happening, but we haven't done a good enough job of publicizing how much we do for physicians. So a lot of physicians will come up to you and say, you guys don't do anything. And they have no idea, none whatsoever. And I was concerned that we should try to be more proactive. But I find that large organizations like the AMA have a tremendous inertia. It takes a long time to move things along. So by the time you're getting them to move, bad things have already happened. So at last year's meeting, I said they should have a rapid strike force. They should have a force. When a new problem comes on, they should have a group that can actually move quickly to assess the new problem and start to begin to formulate actions and getting the board and others interested, and so that you can formulate a plan for how you're going to deal with that.
So you bring up an interesting point about the evolution of the society, and that it initially was an organization that looked at credentialing physicians and educating physicians, and now you're referring to the fact that a very large part of the business of the Massachusetts Medical Society has to do with the government and legislation, large organizations, regulations, those sorts of things.
Right, and the problem was that there are two problems. One is the digital transmission of the journal, which is our bread and butter, was complicated, and I realized that there had to be some risk taken, and I understood that full well, and it was hard to bring some of my associates along with that thought process. there were some very conservative officers who thought, we shouldn't spend money and so forth. But I said, in this day and age, you can be in business this month and out of business in 3 months in the software world.
Sure.
So that was a transition that needed to take place. But the next major transition is how to help employed physicians have a role in these large organizations that they belong to, because that's the future. Most people are going to work for a large organization. At this time, physicians are in demand enough so that if they don't like where they work, they just quit and go to the next. They don't fight. They leave and go to the next organization. But once there are only large organizations, then how do you work? Do you have a union? How do you have a voice?
So that's a very interesting point. In the past, the medical society has focused on educating physicians regarding the science of medicine, and you're pointing out the fact that physicians are joining these top-down organizations in which they have very little power, and you're saying that the opportunity exists for the medical society to essentially flatten these organizations and assume more responsibility among the clinicians.
Right. And in terms of the education, I thought that I've had a couple of meetings with Chris Lynch, and I've talked with the people, I've had dinner with the people at Watson, and sort of trying to move people towards coming up with information that's problem-based at the site of service. Mm-hmm. So given that you heard today that some people don't have the time to read at night, but what if you could be seeing the patient and go online and quickly see a 5-minute video solving your problem?
Mm-hmm.
You would learn, because a lot of our learning is problem-based. Mm-hmm. I can remember the first patient I had with hepatocoma today. I know her name. It's like 50 years ago or 40 years ago. So that was something, but it's interesting to try to, IBM wants to operationalize and make money. So they said, Ron, we're not into research projects, but we'll talk to you. And some educational companies, are interested. So I've been juggling people to try to get everybody. They all realize the value, mm-hmm. but who's going to take the lead in doing this is the issue. We have the data here. We have the information here. So we could be a leader in that, but it's obviously cost money to do this, and I can't seem to get the first people online to do it.
So the other part you're bringing up is the fact that the Massachusetts Medical Society's financial model itself is dependent a little bit on dues and a lot on revenues from the New England Journal of Medicine, right. which itself is entering into a new era of publishing that right. Is a threat to its status quo.
Right. So that evolution is critical, but I really believe that this on-the-spot education and learning is a tool that would not only improve quality, but would really engage people in your business, your model, mm-hmm. and so forth. Because I find that I would do that in every hospital. Every computer in our hospital is internet access, and I would pull papers and leave them for the residents. Mm-hmm. And nobody reads anything. They don't even read my consult. So mm-hmm. there's so much time pressure. They need it quick, so they'd rather talk to you for 5 minutes than read your consult. Mm-hmm. Because you could give them the skinny on what's going on faster than they could read a 3-page consult. So that's the state of the art. Mm-hmm.